Everyone, my name is Sapna and I'm a part of the WomenLift Cohort B 2024. I'm currently working as an international public health consultant with a focus on quality of care in tuberculosis and maternal and child health care. My leadership project looked at trying to understand what are the barriers and enablers for women leaders within the Indian public health services, the government funded vertical programs, to sort of look at what are the gender equity factors around this. The genesis of this project was my own experience at the district and at the sub-district levels, as well as state level, where I saw a very clear pattern of women at the front line and women at the apex of decision making, but somehow the middle level, the mid-range level, where a lot of the day-to-day administrative and decisions, administrative responsibilities and administration were primarily mostly in the hands of men and not too many women. And this when a lot of deputy secretaries and assistant directors were women, but very few directors were women themselves. And this intrigued me. And as I sort of progressed in my own public health career, it was not too much of a surprise why women were facing barriers, systemic barriers at every level. However, I wanted to try and unpack and see if there were certain other political economy factors operating within the government health services that we were not privy to. With this sort of background, I went forth and spoke to close to 20 people, stakeholders, both folks in service and those who have retired, predominantly women, but a few men as well, because I wanted to make sure that it was just not a woman's perspective that I was capturing. And what I essentially did was through a series of conversations, try and understand what has traditionally been the challenge and how things could get better from here, or what is a sort of ecosystem and support that we could provide women both to grow in numbers as well as at a very qualitative level. One thing that distinctly came out in conversations with all of them were that things have improved, albeit slowly, compared to even 20 years ago. Now you're seeing many more women in the workforce. What I have put for you in this slide is a lot of the common themes that emerge in the conversation. Again, not new to what we have experienced in our public health careers or global health careers as well. One thing that really intrigued me, though, was that their individual and family expectations of a public health career in the government was a preferred option, because many of them felt that this was a 9 to 5 job. It was secure, and then there would be enough time for all of them to give the family, and hence public health careers were a preferred option over a clinical career. When I probed on what is it that a lot of the women required to be emerging leaders in their space, what again I received was not very different from what we've all heard in other spaces. They were all very attuned to the fact that many of us in the development space had international exposure, travels to conferences, all of which were limiting in their own space. The other thing is that many wanted a more objective and transparent system of assessing their performance, and not but just based on seniority or political dynamics. I am hoping to continue probing into this matter more and more, and understanding and unpacking more over the course of the next 1 year. I am just concluding with this picture, which I took during my recent visit to Mahakumbh in Prayagraj, and it sort of symbolizes for me a new beginning and going into uncharted territories. And I say this because the global health sphere has changed radically in the last few weeks, and this has a bearing on my career and a lot of us public health professionals. On that note, I would like to thank all my cohort mates and the organizers at WomenLift and my coach for this amazing year and experience. Thank you.